Dilatation and massage. One of the most difficult problems in the treatment of chronic urethritis is the intelligent use of dilatation and massage. Theoretically, every sclerotic anterior urethra should be dilated until the sclerosis disappears and the surface of the mucous membrane appears healed when observed through the urethroscope. Theoretically, every inflamed prostate and seminal vesicle should be massaged until it no longer yields pus. Practically, the most successful practitioners honor these rules more in the breach than in the observance. Many an anterior urethra becomes and remains apparently well, though it bears untreated scars. Many a prostate continues to excrete pus, in spite of all that can be done by the most vigorous and long-continued massage. Indeed, if one follows these cases as I have done, treating them up to the point of clinical cure, then observing them, and massaging the prostate as part of the observation every few months for a year or more thereafter, one is surprised to note that a prostate, the treatment of which was stopped with some misgivings, will often show less pus in its secretion several months later than it did while treatment was being pushed. If relapse is noted after the interval, especially if that relapse be only in the shape of an increased amount of pus in the secretion, without any subjective symptoms or urinary signs, a few rubs usually set things right again. On the other hand, if dilatation is persisted in until the urethroscope shows a perfectly satisfactory condition of the mucous membrane, or if massage of the prostate and vesicles is persisted in long after the disappearance of symptoms and urinary signs, in the hope of expressing a last pus corpuscle from these organs, the case is likely to be sadly overtreated. This is especially true in the matter of massage. It is almost impossible to remove the last trace of pus from the prostate, the seat of severe or prolonged chronic inflammation. After a thorough course of rubbing with this end in view, the prostatitis is quite as likely to relapse as though the patient had been more moderately treated with a view to controlling and not eradicating the prostatic suppuration. Relapse after such a course of treatment is the making of a sexual neurasthenic. The fear so commonly expressed both by the profession and by the laity that chronic prostatitis leads to prostatism is without clinical foundation. In the report referred to, I have shown that, among men of a given age, prostatic retention is less common if they have suffered from severe and prolonged prostatitis in their youth than it is among their more fortunate brethren who either deny gonorrhea absolutely or, at most, have not had severe prostatic inflammatory complications from this disease. Were prostatitis so much to be dreaded as a cause of prostatism, as some of our brethren maintain, given the fact that prostatitis is so common a complication of gonorrhea, as these same brethren gladly admit, one might expect to see in the generation which has now passed its 50th year, and which went through its gonococcic period at a time when no finger invaded the prostatic penetralia, an overwhelming proportion of prostatics, many times more than the clinic actually shows. Theory of dilatation and massage. The important pathologic changes of chronic urethritis occur chiefly below the surface, in the glands of the anterior and the posterior urethra, and in sclerosis of the mucous membrane about these inflamed glands. The reason for employing dilatation of the anterior urethra and massage of the posterior urethra in the treatment of chronic urethritis is, therefore, twofold. First, in order to express the accumulated secretions from the glands, and thereby to permit them mechanically to return to a more normal condition. And secondly, by making pressure upon the inflammatory tissue about these glands, and especially about their orifices, to encourage resorption of this exudate and to discourage its change into a permanent scar. Footnote: the use of electricity, Newman, hot solutions, or hot sounds to excite hyperemia and replace dilatation has not met with any general success. One might suppose a priori that every chronic urethritis, therefore, required either dilatation or massage, and more probably both, but such is far from being the case. Some inflamed urethras heal not only as well, but even better without these measures. Massage of the prostate and vesicles may prove irritating rather than beneficial, and the danger from irritation by the use of sounds and dilators in the urethra is well known. Moreover, the moderately inflamed anterior or posterior urethra gets well without mechanical pressure in many instances. Hence, it is well to reserve massage and even more carefully to reserve dilatation for those cases that really need it, that are not curable without it. One can scarcely be too enthusiastic about the advantages of these methods of treatment if one always bears in mind their dangers.